to have Dr. Hussein Kanji presenting for us today. He's a close friend of mine. And to give you a little background about Hussein, he completed his undergrad degree in physiology at McGill, followed which he pursued a master's degree at the University of Calgary. After that, he pursued research as a fellow at MIT, where he was involved in developing a novel heart failure model and EKG monitoring device, which has now been patented. After completing medical school at the University of Calgary, he pursued both a residency in emergency medicine while completing his Master's of Public Health at the University of Alberta, following which he is currently finishing a fellowship in critical care medicine at UBC. Most recently, Dr. Kanji's research interests have involved around echocardiography-based resuscitation and ECMO for ARDS. He's received many accolades and grants for his work, including the 2013 Society of Critical Care Medicine in Training Award, Research Citation Award, the Canadian Association of Emergency Medicine Research Grant, the National Resident Leadership Award, the MIT School of Science Outstanding Achievement Award, and finally the Canadian Critical Care Merit Award for Outstanding Research. It's quite a mouthful. Today he's going to be discussing with us new advances in resuscitation and ultrasound-based resuscitation in early shock. Thanks so much, Dr. Kanji.
Thanks so much for allowing us or allowing me to present on this topic, Dave. As you know, I certainly appreciate Dr. Sweet and the BC Council and the Sepsis Network for inviting me to present on this topic. I'm quite excited about this topic because I think this really is going to be the future of what I think and how I think we're going to be able to manage individuals in the critical care setting. What I'll do is hopefully spend the next few minutes discussing the presentation and really hopefully setting up a platform where we can have a real lively, hopefully, discussion on the topic and bounce some ideas and our utility of ultrasound in the critical care setting. So I have no real disclosures to be made with regards to this presentation, except that I'm very biased towards echo, and I'm certainly very fervent on the topic, and I think that'll hopefully come through as we proceed. The objectives then would be basically, I'm hopefully going to take a little bit of what the data has been with regards to ultrasound and resuscitation of shock, look at what has been actually validated, and then present the data of our recent study that we just finished conducting and are just sent out for publication. So I'm really excited to share some of that data with you guys this morning, and again, hopefully have some discussion with regards to that. As I mentioned, I don't think echo, I think echo is certainly the future. Ultrasound is the future, and some may even argue it's the present. I think the utility of ultrasound for those of us who use it on a day-to-day basis it's so, I guess, useful in every sort of setting, certainly in managing a critically ill patient. The information that we glean, the management decisions that we can make, again, I think it's going to become an essential part of every physician who deals with acute care medicines, part of their armamentarium in dealing with patient care. So I'll start off with a story, with a little bit of an anecdote. A few months back, and you may recognize the picture on the screen of Ron McLean. Despite the Canucks having lost, I thought we'd introduce some hockey into this morning's presentation. And this is a picture of his wife, who was actually who was diagnosed with a pulmonary embolism because of the use of point-of-care echo. So the quote there by the emergency physician was, "The ultrasound machine let him rule out internal bleeding. Then he scanned her heart and saw the right ventricle much larger than the left, signaling a pulmonary embolism." So here it is, echo being used even in the world of hockey remotely, I guess. But the utility of something at the bedside that can really help us make management decisions. Let's take it to a case that I think is a little bit more up our alley, certainly for those of us in critical care and even emergency medicine. This is a case I saw a couple weeks ago. I got a call from the emergency department of a 67-year-old male who was presumed urosepsis. The vitals were 38.3 for temperature, heart rate was 121, little hypotensive at 88/54, minimal urine output, and sats for 94%, having just been intubated on an FiO2 65%. Already about 4.6 liters of saline had been administered. A little bit of a white count. The central line had been placed in the emergency department, and mixed venous sat had already been sent off at 62. Again, noted that the lactate was 4.7 here. The antibiotics had been administered, and CVP was 13. So historically, I think many of us, and maybe not even historically, currently, I think some of us would have said, well, all right, we've got a central line in place. I think it's time we start vasopressor therapy. But concomitantly, I think the fluid challenge would have potentially continued, especially with regards to the minimal urine output, the lactate, and look at our ability to maybe clear that lactate and start to resuscitate this individual with vasopressors in addition to fluid resuscitation. The interesting part here is, and unfortunately I can't get the AV films up on the screen here, was when I put a probe on this individual's heart, there was significant, severe myocardial dysfunction. In addition to that, the IVC, the intra vena cava, was engorged, and there was little collapsibility in that. And that really altered my management immediately at that point in time, and we restricted fluids on this individual and started the butamine and a little bit of vasopressor therapy in the way of Levophed. This allowed this individual urine output picked up within 2 hours, and we actually started to clear the lactate, and as well as we were off essentially all vasopressor therapies within almost 48 hours, but almost 24 hours, but certainly at 48 hours. And we see the myocardial dysfunction, which I'll talk about in a minute, had almost entirely resolved within that time frame as well. So this is something where, you know, echo for me, and the utilization of echo in the resuscitation of this individual really significantly altered my management decisions. And someone who's FiO2, and I didn't note the PO2 here, could have been quite low, but the FiO2, we could have been flooding the lungs with concomitant fluid administration. And really, the big question is how, I think, do we limit our fluid in resuscitation of these individuals? You know, Rivers does a sort of great idea, you know, gives us a bundle which we can follow. And in addition to that, the surviving sepsis guidelines, which I'll get in a minute, also give us a good background in which we can resuscitate. But when do we limit our resuscitation, and how do we titrate that? And I think echo really is where this plays into individuals. Not only why I use echo here, the first point being elucidate the etiology of shock, because as I mentioned, I think primarily, especially much like this example, the etiology of shock is often mixed. There's an under-recognized cardiogenic component, which can be managed far differently. As well, it gives us a real-time insight into the response of your resuscitation. We're not reactive. We're not waiting for certain values to come back, such as a lactate or a mixed venous sat, but are allowed to see immediate fruits or harm of our resuscitation efforts and make titration within that, So I think our current approach certainly is one that has been tried, tested, and true, the Rivers protocol, and again, I'm just referring just to septic shock right now, not overall undifferentiated shock, which I think echo is even better for, but there's certainly limitations in our current approach of shock here, and they're quite evident. And just the severe, surviving sepsis campaign here, a quote directly from their most recent publication here, is that the committee, and I'll read out what was read in red here, and it says, while the committee recognized the controversies surrounding resuscitation targets, using CVP and venous blood gases can be readily established in both emergency department and ICU settings. So this still seems to be the standard of care because it's readily available, but there's certainly a huge amount of controversy around what CVP, how much to resuscitate, when to stop resuscitation. And, you know, the surviving sepsis campaign bundles, again, which is recapitulated in this table, shows that, you know, within 3 hours still we're trying to achieve what I think is, you know, very achievable, nice targets to go for. But again, within the 6 hours, we're still doing things such as mixed venous sats, CVP targets, and these techniques, again, I feel have a lot of limitations in what sort of data points and information we can glean about the patient. And again, my personal bias is that these are quite reactive techniques, certainly with regard to mixed venous sats and lactate, and the CVP we know has a host of limitations, some of which I'll be discussing in a moment. Again, we're sort of not sure what is the best technique. We have this great sort of platform of how to approach the septic patient in terms of, getting adequate fluid resuscitation, going down an algorithm which has, again, been shown to be very effective. But when we look at how to titrate our management, I think there's some holes in the treatment. Again, lactate clearance versus central venous stats, they've shown by this JAMA paper, again, that by and large equal, and you can target one or the other, looking at sort of a clearance of the lactate within the 6-hour regimen that had been already stated. Again, going back to the issue of CVP, and one of the issues that I certainly have, and it's fallen by the wayside, I guess, a little bit in more recent times, is that the effect of CVP to actually measure the effectiveness of your resuscitation is quite limited. It can be limited by simply the ventricular compliance, the tricuspid valve regurgitation. The amount of resuscitation or intravascular volume is not necessarily shown by your CVP, and in fact there's a study showing at later time points out after 12 hours it certainly becomes a poor marker of intravascular volume and volume overload at that point in time. And in fact it's those that have lower CVP that there is a propensity perhaps in an adjusted hazard ratio of survival. So perhaps this should not be the endpoint that we are actually targeting, and echo may be something that we can use a little bit more effectively to gauge our resuscitation. We know, and I think the big thing, and the thing that I will sort of explain or go into a little bit more with our study was, interestingly, I think echo allows us not only to recognize the etiology of the shock, but really limit our ability to resuscitate individuals. Again, we know that too much fluid is harmful. This data is becoming more and more prevalent now. We can see that cumulative fluid balance, again, from the SOAP study, being an independent predictor of harm in these individuals. And, in ARDS, we're well aware of the data that shows that, increased ventilatory days as well as ICU-free days with liberal fluid strategies is much higher. And there's certainly harm that's associated with this, and something that I think we should really think about titrating. So here we are, we're at the crossroads. We're not sure exactly which way to go and how to titrate management, whether it be mixed venous SAT, CVP, physical exam, lactate clearance. There's a lot of tools for us. But I think echo personally is something that we can be using at the bedside as point of care, and really something that can affect and alter our management. The big issue here is we don't want to go down a path where we're going to hit a dead end, and we want to be able to navigate out of this. And again, all these markers that we're going to be using are hopefully helping us veer away from this. And much like, and I explained to the residents that I think, getting someone out of sepsis is like flying a plane and just landing it very, very smoothly using all the tools and data points we can have. I think echo is one of those data points that is not only very effective, but can be used in a serial manner to assess our effectiveness of resuscitation and what can be done. So why then use echo? I hopefully have made a bit of an argument here so far of our limitations of our current methodology and our ability to resuscitate individuals. But I think there's something, as I alluded to just earlier in the talk, with regards to cardiogenic induced or septic-induced cardiomyopathy. I think this is a largely under-recognized phenomenon that has been reported for almost decades now, and the incidence of which is alarmingly high. Somewhere in the realm of 40 to 60% of individuals can actually have a cardiogenic-induced, cardiomyopathy secondary to sepsis. And I think if we recognize that, we look for it, our management strategies can often change, much like the example I sort of illustrated at the beginning of this presentation. What does it do? Well, using echocardiogram or echocardiography or ultrasound at the bedside certainly changes management. In this study, you can see it modified, and don't worry about the small font in the table, but just highlighting the fact that the diagnosis was modified about 25% of the time when bedside echocardiography is used. It prompted more testing almost 20% of the time, and changed therapy, again, almost 17, 20% of the time in these individuals. This has also been recapitulated by a nice study by Manasia. This, again, was training intensivists using bedside point-of-care echo, 10 one-hour tutorials. They were very successfully performed. And again, altered management, and almost 40% of individuals or patients in which this ultrasound was used at the bedside. Again, sometimes the question is how much extra time does it take? Again, roughly about 10 minutes for this to be conducted at the bedside. But you can see the fruits of which are huge, right? Especially earlier on, if we're talking about that golden hour or the golden 6 hours or whatever it is that we appreciate as being very important in early resuscitation of these individuals. I think echo can give us very, very good feedback earlier on, and certainly has the ability to change management decisions. The question you can propose to me then is going to be, well, how does it change? And something I'll get into a little later, because I think there's a lot of data showing that there's effectiveness and there's change, but what sort of outcomes are we actually measuring, or are we actually, achieving with the use of ultrasound at the bedside? What I'd like to talk about now, again, with regards to just the fluid, we have the ability to, and what has been validated in a couple of studies at least, is the ability to manage fluid responsiveness. This is a study done by Faisal. It's a little dated now already, I think, in 2004, where he looked at IVC collapsibility, and based on the receiver operating curves, came up with a number of roughly about 12% in this cohort of patients. Again, there were 39 patients in this study. They were volume challenged with HCCs, and they used what's known as VTI, or just basically the velocity time index around an aortic valve, to measure the cardiac output, and looked at the volume responsiveness of an individual, and came up again with a positive predictive value of about 93% and a negative predictive value of 92%, with using a 12% cutoff. Barbier did a similar study. This time he actually titrated and used 7 cc's per kg over 30 minutes in 23 patients, and found that there was actually 90% sensitivity and specificity when there was a variability of the IVC collapsibility of 18%. As there was more variability, there was more volume responsiveness. They found that as well. And in these individuals as well, the tidal volume, and I should mention both of these were in intubated septic patients, the tidal volume was roughly 8 cc's per kg, and the PEEP was about 5. So with regards to the external validity of the study in your patient population. Superior vena cava has also been shown. I'll glaze over this, but it's the same idea. It's shown at higher numbers at roughly 35, 36% in the collapsibility. This was done with a 10 cc kg bolus as well. And so I think, that being said, our ability to actually look at IVC collapsibility and volume responsiveness has been shown, and it's a really, really effective tool, and surprisingly easy to do when you've done it several times over. It doesn't take a lot of expertise, and really it's a real-time measurement to allow us to know, is what I'm going to be doing to this patient going to be increasing their cardiac output. In addition to that, I think that's one piece of the echo puzzle that I think is really important, specifically in resuscitation of individuals. But the second is with regards to the accuracy of cardiac function and volume estimates. So this one was done by 6 surgeons and surgical fellows, and it shows that even surgeons can be taught an echocardiography here. We're looking at 85 patients, but there was a great correlation between the investigators, and they actually were effective in finding out what sort of left ventricular ejection fraction or contractility in these individuals. In addition, looking at left ventricular systolic function, again, the last bit, don't concentrate on the table much, but they showed that there's a very good correlation between just eyeball estimation of ejection fraction, and they showed in this study that despite over several days, there was actually improvement in the ejection fraction of these individuals in septic shock. And again, just going back to the fact that a lot of people say this is very difficult in ventilated patients, I think it's important to note that about 97 to 99% of individuals in this study were able to actually acquire good images. So who can learn? Basically, anyone can learn. This is a study done at the bedside, looking at non-cardiology residents, showed that just a 3-hour didactic and a 5-hour hands-on had a good kappa value. They were able to actually generate very good images, just residents using at the bedside, and this was a very teachable skill that should be used, I think. So is it for all? It's feasible. You can learn it. You can apply it. Again, I think the big thing is, what are the outcomes here? And I'll just jump over and glaze over sort of our study here, because I think a lot of the stuff has been validated in terms of volume responsiveness, the utility, the ability to learn, but we don't have much data, and I think ours is the first showing that there's actually some outcomes generated here that I think the utility is then justified. So basically, we looked at, just summarizing, it can be difficult, again, to know how much fluid and when to titrate fluid management. And especially when you're initiating inotropic therapy, we do it based on mixed venous sats and core perfusion, but if you have a reliable measure of cardiac function and echocardiography, this really allows you to properly titrate your management and allows us to make, I think, educated decisions at this point in time. So we asked the question, does standardized echocardiography affect fluid prescription at 4 days? And then the secondary were, what are the days alive and free of mechanical ventilation, alive and free of inotropes, alive and free of renal replacement therapy, and essentially 28-day survival. We used a before and after study design where we enrolled patients with vasopressor-dependent shock and used standard measurement in the control arm, and then management guided by early standardized echocardiography in our intervention arm. And we had 4 standard views, essentially the peristernal, the apical 4, and the subcostal, looking at IVC collapsibility and contractility, which are basically our 2 major outcomes. So IVC collapsibility and generalized contractility were our 2 data points that we used. And we put them into this algorithm. So we looked at an IVC variation that was large in the first 2 boxes. If it was associated with LV dysfunction, we said we would give them volume plus an inotrope and dobutamine. In the 3rd box, you see that there's a low variation with depressed function. So we'd restrict fluid in those individuals with dobutamine. And if there was normal EF and in the 4th box, a low variation, we would essentially only restrict fluid and recommend those. So this was the algorithm we'd set up in terms of how to manage these individuals. The patient demographics just looked at, essentially it's a pretty sick cohort. The Apache 2 is about 24. They're equally distributed between the 2 groups. The cause of vasoshock was essentially septic or vasodilatory at about 70%. And comorbidities were equally distributed amidst both groups, both the standard and ESC groups here. And when we look at just some of the lab and vital signs sort of between the 2 groups, there was only 2 differences. The blood pressure was a little lower and the heart rate was a little higher in our early standardized echocardiography group, so our ultrasound group. Maybe pretending that this was a sicker cohort that was just selected out. The findings we found was essentially there was significant valvular pathology in about 20%. And again, when we look at the combined moderate to severe depression of cardiac function, you're looking at about 40% of our individuals that we probably would have missed had severe to moderate myocardial dysfunction. When we look at the collapsibility, I think the important thing here is that about 65% of our patients had no collapsibility at all, and 21% had very little. And that resulted in us essentially restricting fluid in almost 70% of these individuals in whom we performed this early standardized echocardiography. That, I think, resulted in a significantly lessened volume and cumulative IV volume balance, not only from the first day, but cumulatively at 4 days out between the 2 groups. And in addition to that, we had a Kaplan-Meier curve that shows certainly a lower, sort of an improved survival in the early standardized echocardiography group at 28 days out. In addition to that, we see that there's days in alive free of mechanical ventilation and free of vasopressor was also higher in the early standardized echocardiography group. We didn't achieve significance in the renal replacement group. But when we use, and as a sensitivity analysis in a multivariate regression, the use of early standardized echocardiography in this group was associated with a decreased odds of mortality. So in conclusion then, I think the use of early standardized echocardiography significantly decreases the prescription and cumulative fluid balance compared to standard management. We show that there's days alive and free of mechanical ventilation, days alive and free of inotropic therapy is improved in both these groups, and more importantly, there's a lower adjusted 28-day mortality. This is a before and after study, so we need, future RCT to actually corroborate the results of this. But in a bigger picture utility, I think ultrasound specifically with regards to management of our critically ill patients, this is the future, this is the present. I think the utility is just, there's so many pieces to this puzzle in which we can manage our individuals and allow more information for us to make better decisions at the bedside that I think we'll be seeing more and more about this. So with that, I'd like to open to discussion and any questions, and I hope it was effective, and I hope I was able to partake a little or educate you a little bit on what I think is a very interesting topic and something I'm very passionate about.
Fantastic, Hussein. Thank you so much for that talk. An incredible talk as always. I'd like at this point in time to open up to the rest of the attendees to see if anyone has any questions. You can put your hand up using the panel with the hand up icon if you have a question. While people are waiting or thinking about questions, why don't I start with a question, Hussein? The first question I had was, in your study you found a significant portion of patients had valvular pathology in their initial echocardiography. I'm curious, what valvular pathology did you find, and was it just an incidental find, or did you record if that finding had any changes in management ever?
Yeah, that's a good question, Dave. It's so we found a whole from mostly incidental findings. So basically, our algorithm in the study was that if we found a valvular abnormality, that was an initial sort of tick box to send them on to a formal study to get that evaluated, because it wasn't our purpose, and I don't think we should be in the business of diagnosing or calling valvular abnormalities in the ICU. As we step on cardiologists' feet or territory a little bit, but the most significant of which was mitral valve, and we had certainly some that were significant, but and would alter management in that situation, and we would consider that in making the management decision. But by and large, I think these were incidental findings and didn't have much in the way of, I think, hemodynamic implications.
Great, thanks. One other question. Before echoes come into the spotlight in the last couple of years, there's a lot of talk about using passive leg raise for ventilated patients and determination of volume responsiveness and septic shock. What are your thoughts on passive leg raise, and do you think there's any clinical utility there? Do you use it in your clinical practice?
Yeah, it's funny you say that. Our next study we're actually thinking about doing is looking at presented sort of two pieces to the volume responsiveness. And I think, as you know, leg raises is actually pretty effective in knowing how to, it's giving some volume back to the preload to hopefully effectively increase cardiac output. I think if you use it from an echocardiography standpoint, I don't know of any studies that have looked at it, but it would be an interesting non-invasive way to actually look at your volume responsiveness, and certainly in crash situations we can use it effectively and know it works. But we want to just elucidate more, not only from the effective IVC collapsibility, but more on the corollary. We're actually thinking about maybe standing patients up or sitting them up to try to, increase that venous capacitance and look at maybe patients are a little too overloaded and looking at IVC collapsibility at that point, if that makes sense. So the ability to actually diurese patients now based on echo findings, which I think is maybe the next step. But I still, yeah, so I think that I think the most interesting thing that I think that we found was that we were over-resuscitating individuals or patients. 70% of patients we were restricted volume on. So I think, you know, the algorithms that are set out are very effective, but are overly aggressive. So I think we need to, I think echo will allow us to maybe titrate those back a little bit and make changes.
Yeah, I know. I've always found with passive leg raise is that a lot of the patients that are ventilated you're trying to use it on, either one, they're heavily sedated, and then you can use your pulse pressure variation as a guide to volume responsiveness. The ones that aren't as sedated as much, when I try using my passive leg raise, it seems to agitate them just enough that it may change the hemodynamic parameters you might be looking at to see if they're responding to their volume. So I've always thought an interesting study would be having someone who's relatively sedated and then look at echocardiographic changes with passive leg raise to determine the amount of volume that they're capable of handling or their volume response with just that amount. I see there is another question here. Caitlin, can you unmute Chris to ask their question?
So I'm puzzled by case number 1. You said that the CVP was 13, and then you did an echo that showed that would be interpreted as the CVP is 15. You know, why would you consider giving more volume to someone with a CVP of 13? And why does the CVP of 15 convince you not to do that? Or is it the fact that there was depressed LV function?
I think those are really great questions. You know, specifically, I think the utility of CVP, both through the meta-analysis that has been done recently, as well as all the limitations around CVP, I think have been shown to be less and less effective as a measurement of intravascular volume. So as you mentioned, I think primarily the CVP in this situation could have been just decreased diastolic dysfunction and ventricular compliance, which could have raised the CVP up in that situation falsely, or you know, over-exaggerated what is already there. I think the point here is that CVP, in my opinion, is a pretty poor marker for intravascular volume in patients certainly in which the hemodynamics are constantly changing, and we don't know what the myocardial dysfunction is like. And more importantly, I think certainly in this individual, and I've seen many of them, is where we start resuscitating these individuals, and there's a huge, you know, cardiac component to their shock that is under-recognized, and the over-resuscitation can be quite terrible. Again, I don't want people to walk away and say, well, you know, we should really limit and stop our resuscitation without, you know, properly looking or having effective tools, but just really maybe think about this more at this point in time, and we need to validate the utility of ultrasound and IVC collapsibility.
The argument makes no sense to me. I mean, you're looking at collapsibility, and when there's no collapsibility, that means the CVP is 15. And when the CVP is 15, then you decide not to give volume, but when it's 13, you think it's okay to give volume. I mean, you know, it's using echo completely inappropriately, in my view. I mean, you know, if you choose to give people volume that don't need volume, yes, they're going to do poorly, but you don't need echo to avoid that.
Yeah. Okay. So I think the argument is that a CVP of 15. I never said there was a CVP of 15. We're using IVC collapsibility. So IVC collapsibility.
So zero collapsibility corresponds to a CVP of 15. All the literature says that.
It can in certain situations. So I think the IVC collapsibility is variable, right? So if you're going to say essentially not, it could be 15, it could be 20, and in this situation you can show that IVC collapsibility doesn't necessarily correlate to IVC collapsibility doesn't necessarily correlate to the CVP solely, specifically in intubated patients and those in septic shock. So there's a whole plethora of data there that is going to show that depending on what the IVC collapsibility is, your ability to actually have volume responsiveness is going to be altered. And again, the association between, I think, personally, I like to step away from the notion of CVP because I don't think CVP shows one, volume responsiveness, and two, it actually targets a poor intravascular filling or volume status. And we've shown that in the Boyd paper as well. At 12 hours out, you're looking at, you know, your ability to actually titrate management based on CVP in septic patient, I think, is falling by the wayside a little bit. And that's my opinion, and that's what I think I've read in the literature so far and what we've seen in our study as well. I'm not saying not to give fluid in those individuals that need fluid, but I'm saying using measurements such as IVC collapsibility as well as integrating it into something that looks at contractility allows us the ability to make, I think, better management decisions than CVP alone.
I think the study needs to be tightened up dramatically. It's interesting data, but historical controls to me mean nothing. And, you know, I think you need very tight protocols on both sides of the equation to say that one is better than the other. And, you know, I think you need proper randomized studies with rigorously controlled protocols on both sides of the equation, not one side of the equation only.
Oh, I couldn't agree with you. I couldn't agree with you more. I think the start of this study is that you have to do this preliminary work. So before and after study we did right at the time of the initiation of this therapy, and we collected data all the way up to that. So we're looking at standard management that was basically Rivers protocolized septic management, and then applied this new ability to actually manage or change individuals. I'm not saying that, you know, we should. The issue is that, and I think what you're trying to get at is that exactly what people are doing a little bit is that, well, echo is, and I don't want to by any stretch saying echo is the be-all and end-all. I think we need data to show that it is actually effective, and I think there's a first of hopefully many and better studies that will go out there and show us that it is effective. I think we know that CVP, in my opinion, is a little antiquated, and look at volume responsiveness doesn't work. When we look at volume response, when we look at our ability to resuscitate based on mixed venous sets, we're looking at a delayed approach or a lactate clearance. We're looking at our resuscitation and waiting for things to occur. I'm not saying ignore them, but use this as a corollary to that, and we can come together and collect more data points to make very effective decisions at the bedside. You're absolutely right. When it comes to this, this is not a panacea right now, but we need to study this a little more, and the effectiveness I've seen, at least we've shown some study, I think, in a relatively, for its study design, a relatively robust study design, some ideas, because if you're going to use this at the bedside and make decisions without having any outcome data whatsoever, this is the first that we're presenting some outcome data to show that there may be some effectiveness. But I hear your point exactly, and in fact, that's what we're working on as the next step.
And I might say a quick thing there too, is as far as my understanding is the correlations with IVC diameter and changes in IVC diameter and trying to correlate those to CVP have been very well studied in the non-septic shock patient, where a lot of the literature looking at the septic shock patient and trying to use CVP as a predictor of volume responsiveness has shown that it hasn't panned out. Where we're starting to look now more at IVC collapsibility in this patient population, specifically being the septic shock patient, we are seeing a more positive correlation with volume responsiveness and the changes in IVC collapsibility. So I think the patient populations might be slightly different. Anyways, any other questions? I might have one final question for you there, Hussein. Do you think there's any place here for some form of automation with identification of IVC collapsibility and echographic changes versus teaching the learner to have to do it at the bedside? Have you heard anything out there about something similar to the an NG2 that is able to measure cardiac output, looking at velocities in the aorta, something that can look at the IVC or to somehow identify severe left ventricular cardiomyopathy, et cetera, septic cardiomyopathy that's automated versus having to teach the individual and the problems that may go along with that?
I think it's a good point. I haven't seen anything out there myself in looking at automation per se. As you know, someone versed in echo, very highly versed in echo, is so much variability. And it's funny that when we look at all so one of the studies that presented, just looking at measuring ejection fraction in individuals, all 6 sort of techniques have been tried, the biplanar, the different ones, looking at the ability to look at contraction, and the eyeball estimation has been almost, especially in this study, looked at having not only good correlation, but sometimes better correlation or better outcomes So I think it's really tough to automate something like this. Certainly with that possibility, it might be better, because I think the natural, and I've done this too, is sometimes put the probe on someone and then say, oh, there must be 15%, 20% variability, and we really shouldn't be doing that. We should be looking at sort of the M mode and calculating it properly. So there may be some utility in that, but I don't know much otherwise.
Oh, we have one final question from Dr. Dodick. Go ahead, Dr. Dodick.
A quick word to just applaud. I just want to applaud Hussein and his co-investigators for doing this work, for improving the predictive value of the diagnostic tests we use in the ICU. For many years, we've done our best using clinical physiology and sometimes extrapolating from the normal state, but we know that critically ill patients are not in the normal state. So thank you very much for being careful. I realize this is a beginning of a whole research program, and I encourage you to continue to help elucidate the role of this diagnostic technique for us. Thanks.
Thank you, Peter. One final, we're almost at time there, but Dr. Sang, I see you have a question. Oh, I think we're having some computer issues.
Yeah,
John, are you able to?
I unmute him now.
Okay.
Okay, so he's not connected to sound. I'm just going to mute the call-in users and see if that ends up being him.
John, are you there? Oh, unfortunately, I don't think that we're going to be able to get that question.
You can try to type it into the chat box.
Well, John's doing that. I may just say a couple words. I just want to thank everyone for coming to this lecture. We have some really exciting upcoming lectures, and as you can see here, that next month we have Dr. Nan Kumar speaking to us on antibiotic therapy in sepsis patients and the importance of early initiation of antibiotic therapy. You can see that's on Tuesday, April 23rd, so please put that into your calendars. If you haven't yet joined the BC Sepsis Network, you can go next slide there, Caitlin.
Yep.
BC Sepsis Network, please join. You can see, oh, one back with the website there. Oh, there. One more. There you go, bcsepsisnetwork.ca. Could you please join? We distribute a lot of information through this site, including the times of our lectures, and we share a lot of resources, etc. Next slide. And through the BC Sepsis Network, again, we have the Q Exchange with www.qexchange.ca, which is another place for us to interact. And we've created a community of practice for people looking at improving sepsis work in their departments, either being the emergency department or other wards within the hospital and the ICU. Next slide. And so thank you very much for coming, and we'll have this presentation online. Please share with your colleagues about this lecture and encourage them to come to the BC Sepsis Network and to view this lecture and lectures from the past. So I want to give one final thank you to Dr. Hussein Kanji. Fantastic work, with fantastic lectures always. Keep up the good work. You really are breaking new ground here, and you're one of the leaders in the world, I truly believe, on the emergence of echocardiography, not only in the ICU and the emergency room, but specifically in the management of sepsis. Thank you so much, and thank you so much for everyone for coming. Have a good day.